Okay, so this next part is really, as Dr. Schackman said, we're talking about the denominator, right? When we talk about cost effectiveness, we're looking at cost relative to a unit of effectiveness. Well, that's what this piece is. Okay, so next. So first I want to just give you a very quick overview of just the general rationale for cost effectiveness analysis. So if we really want to efficiently allocate our scarce resources, as economists always say, right? We know all resources are scarce, and we want to make the best use of those in order to maximize public health, public well-being. We have to account for both cost and effectiveness, right? So if we only focus on cost, for example, we may end up choosing an intervention that is far less effective just to save money, which is kind of what people are scared of, right? Especially in the US, we tend not to use cost effectiveness formulas so much, and this is why. People aren't educated so much on what it actually is. They're afraid this is what we're gonna do. It's not what we do, right? But at the same time, we don't want to focus solely on effectiveness either, right? If you focus only on effectiveness, you may end up choosing interventions that are only moderately more effective, but substantially more expensive. Therefore, we end up using all of our resources on this intervention that really wasn't necessarily the best way to do it, right? We could have helped a lot more people if we would have done this other one instead that was just a little less effective. Next. So, quick question. If we are doing cost effectiveness analysis, which of these would we be able to do? Which of these are we talking about? We're talking about cost per days abstinent, symptom-free day gained, overdose prevented, life saved, life year gained, or quality adjusted life years gained. Anybody have an idea? How about number one? Show your hands. 2? 3? 4?
Last one.
How about, let's jump to the one most people know. How about quality adjusted life years gained? Okay, well in reality we can do all of these, right? When we're talking about cost effectiveness analysis, we are just talking about a unit of effectiveness. Now, there are benefits and costs, if you will, to each of these. So I'll go through that a little bit and kind of talk about why we would want to use one versus the other and so on and so forth. Next. Okay, so we're talking about some of these clinical measures of effectiveness, right? So let's say days with withdrawal symptoms, relapse rates, overdoses, cases of disease, things like that. Well, the nice thing is they're easily available, they're understandable, right? And that's important depending on your audience, especially if you're trying to reach, let's say, a clinical audience. Sometimes these types of measures speak to them more easily, more clearly. One of the downsides is they're not comparable across diseases, right? So if we are talking about how to allocate, let's say, our general healthcare resource budget, looking at how cost effective something is with regard to days abstinent, it's not going to do us a lot of good when we're trying to decide, should we be putting more money into this or into this particular cancer intervention? It's not comparable. The other thing with these clinical measures is that there's no commonly accepted value thresholds. We'll get into that a little bit more later, but what it comes down to is what are we willing to pay to gain a unit of effectiveness? Well, we don't really know for sure when it comes to clinical measures. And not that we know for sure when it comes to some of these other measures either, but we do have a better idea. Okay? The other thing is they do not necessarily account for the broad range of health outcomes that are associated with most chronic disorders. Okay, so when we're talking about something like substance use, for example, there's much more to individual well-being, of course, than just whether or not they're staying abstinent, right? We know that there's all these other things that we should be accounting for, and these clinical outcome measures are not going to do that by themselves. Okay, so what about gains in survival, right? Life saved, for example. Well, the nice thing is it's objectively measured, and then at the same time it weights all lives equally. Well, that may or may not be a good thing depending on our objective, right? If you look at just kind of people's preferences, the general public preference a lot of times is to, let's say, spend more on certain populations, whether it's the elderly or individuals with a disability or things of that nature, right? And we've shown that we are willing to pay more for that sometimes. So maybe we don't want to do that. Life years saved, again, the outcome is objectively measured. The downside is it tends to weight the young more than the old, right? Because there's not as many years left to be saved for elderly individuals. Okay, next. Like I said, so not all health interventions save or prolong lives. That's another thing that we need to keep in mind. Sometimes we may just be looking at improving quality of life, right? Then, of course, there's that whole quality versus quantity argument. We all know that's, sadly, that many interventions may extend life, but the quality of life may be, very low. And so that's something that we want to account for as well. And then the other thing we know is that individuals may not value health in the same way at all stages of their life, right? So that kind of tends to vary over time. Another thing that we need to account for ideally. Sorry, next. Oh, sorry. Okay, so quantity of life, survival, that's one aspect of health. But there's multiple impacts that we need to consider. Benefits, side effects, things like that, kind of as I was referring to before. And also patients are interested in functional capacity and well-being. We know that. So with regard to health-related quality of life, these are measures that are derived from psychology. So there's an emphasis on rating specific domains of health. So we're talking physical function, psychological function, social function, role impairment. And what we can do is we can map these to specific health states, right? So for example, the EQ5D. Many people, who's heard of the EQ5D? Okay, well, it's in terms of generic health-related quality of life instruments, it's probably the most commonly used. It has some nice psychometric properties, low respondent burden, it's only 5 questions. So it looks at 5 different health dimensions. Right? Mobility, self-care, usual activities, pain, discomfort, and anxiety/depression. There are 2 levels. There's the EQ5D 3L or the 5L. As of right now, we recommend the 3L, and I'll talk about that a little more in a few minutes here. But so for each one of those dimensions that I mentioned, the 3L has, you can say, well, I have no problems in this particular area, moderate problems, or extreme problems. Okay? And the way we can do essentially is based on the scores for each of those dimensions, you can create different health states, right? So I had a 1 here, 2 here, 3 here, 1 here, that kind of thing. Well, each of those different combinations will create a health state. And what we can do then is value those health states. Talk about that in a minute. But the EQ5D has 243 unique health states, which isn't a lot compared to some of the others, but we believe does a pretty good job. Okay, next. So the question is, what is utility? Does anybody have an answer to that? Economists love to talk about utility. What is it? So utility is just an abstract measure of satisfaction. So when we're talking about utility, we're just basically talking about happiness, if you will, satisfaction. Okay. So why utilities? Why do we talk about utilities? Why are we interested in them, especially in this context? Well, first of all, with utilities, we're talking about we're incorporating values and preferences for different health states, right? And we know that the two are related. We have all these different health states, and basically the more we prefer one health state to another, the more valuable it is. And so we have, let's say, these 243 different health states. One thing that we know is that you're going to feel one way or another about them, right? You're either going to prefer A to B, you're going to prefer B to A, or you're going to be indifferent to A and B. Well, that's what we're talking about, is indifference and utility, satisfaction. Okay? So we also incorporate morbidity and mortality into a single measure when we use utilities. And they're comparable across different interventions and diseases, which is a nice thing, right? We just talked about how that's kind of a downside to, let's say, the clinical measures of outcome. Okay, so some just very basic properties of utilities. You could go way into this, and we could spend a whole class just on this, but we won't do that, and you'll probably thank me for that. But one thing we know is, so death is associated with a utility value of 0. So if you're not alive, you're not happy, right? I mean, theoretically, you're not anything. So the scale should possess interval scale of measurement properties. What that means is that each value is unique, right? The values have an ordered relationship, as we talked about, and there's equal intervals. So you go from the utility value of 0 to 0.1 to 0.2 to 0.3, depending on what scale we're talking about, that should be the same between each of those. The other thing is that they should exhibit mutual utility independence. So, for example, when we're talking about health dimensions, how I rate how I'm feeling about one should be independent of how I'm feeling about the other, right? So the score that I give anxiety/depression should be different than the score that I give my physical health or whatever other dimension we're talking about. Okay. Next. So how do we calculate utility values? Well, there's a few different ways, and I'll go through each of these a little bit, but one is we can measure the values directly in appropriate subjects. We can use an algorithm, and we can translate some of these domain measurements into utility weights, or we could search the relevant literature and try to assign them based on their particular health state. So we'll talk about each one of those. But so next I'm going to talk about the valuing directly. Okay, so there's a few different ways to do this. These are three of the primary ones. We have a visual analog rating scale, so what we also refer to as a feeling thermometer. There's time trade-off is another standard method, and standard gamble. Okay. All right, so the rating scale is most straightforward. So we're just basically show the individual, show the participant this scale and say, okay, where on this line would you place your, how you're feeling right now, let's say. So 100 is perfect health, 0 is death, right? They might say, okay, well, I would say 65. Well, then we just divide that by 100 and we say, okay, so your utility value, so we're going to do this on a 0 to 1 scale so that we can weight our time, and we'll talk about that in a minute. But so the next slide will just show us that it just says, okay, well, then your utility would be 0.65, right? Okay, next. Okay, so how we do this time trade-off, this is a really good example. We'll just kind of walk through it. So we would present the individual with a question. So let's say you can live 20 more years with a severe opioid use disorder, and that would be explained to them in detail, and I'll show you a good example of that in the next slide. Or 10 more years in perfect health. Which do you choose? Okay, and the idea is we want to vary this until they're indifferent. So we would, we could then change that, say, okay, well, you could live, if they say, well, I would choose one or the other, and we'd say, okay, well, what if you could live 20 more years with a severe opioid use disorder, or 15 more years in perfect health? Which would you choose? And so we can we'll just keep adjusting that lower number until we find that they are indifferent. Okay, so next. Okay, so if they say, well, I'm indifferent. To 10 years in perfect health versus 20 years with a severe opioid use disorder, then we would say for that individual that their utility would be 0.5, okay, on a scale of 0 to 1. For the second, 0.75, and for the third, 0.9. Okay? Next. So the standard gamble then gives us a hypothetical choice between life in a fixed health state for a given period of time, or a two-outcome gamble whose outcomes are perfect health or immediate death. So we're basically saying you're starting with this, right? So we're kind of placing all of that burden, if you will, up front. When you're starting with this disorder, are you willing to take the risk of the cure, if you will? And we will then vary the risk of the cure until we find that point of indifference. Here's another example that Dr. Schackman and some of our colleagues worked on in terms of valuing opioid use disorder states. And I'll go through the example in its entirety a little more in a little bit, so you'll see it again. But so you can see at the beginning, you're getting this very good description of what it would be like to have a severe opioid use disorder, right? What happens when the drugs are wearing off, and essentially how you're going to feel, right? And so we're saying, okay, so you can stay in this state with this severe opioid use disorder, or we have this magic pill, right? And you can take this pill but there's a 50-50 chance it's going to work, let's say, right? So you have a 50% chance of feeling better or a 50% chance of dying. So, that doesn't sound all that great, right? So what do? Well, if we don't take the pill, you're going to stay as is, or you take the pill, be cured, or die. And then we'll kind of say, well, I don't know, that's a pretty high risk of death for me. I think I would rather just live with this disorder. And then we can adjust that, though. We can say, okay, well, what if we up the chance of success to 60%, 70%, so on and so forth. And so that's essentially that standard gamble method until we find that point of indifference and we can calculate that utility value, right, associated with that health state. Okay, so let's talk a little bit about these three different techniques that I've gone over. So the visual analog scale, right, you get a value, however, it's not a utility, right, and there's a difference. So this is more of just a preference weight. It's easy to administer, but the thing is, it's not preference-based. And if we want to satisfy the von Neumann-Morgenstern axioms of utility, so basically if we want to be able to say that this is a utility, that this captures this measure of satisfaction, there has to be a measure of preference in there, right? There is no measure of preference there. We're just saying this is how we feel, okay? So what about the time trade-off? Well, it's closer, right? We do have that preference factor in there, right? But at the same time, we take this hit at the end of life, as we discussed before. You kind of run out of that time to trade off. And it doesn't consider uncertainty, which is another thing that we need in order to be able to state that this is actually utility value. So that brings us to standard gamble. This does give us a measure of utility. So first of all, be careful when you're reading through the literature. It does matter which instrument they used and how those values were derived as to whether it's actually a utility value or whether it's just a health-related quality of life preference weight. But at any rate, standard gamble, it's more difficult, as you can see. There's certainly more work involved in getting those values. But it places all the risk up front. Like I said, right, you have this disorder, and now we're asking, are you willing to take the risk associated with the cure, right? It's directly related to decision theory, incorporating attitudes towards risk, because we're saying there's a certain amount of risk in taking this pill. And it accurately describes the risks associated with many medical decisions. So at any rate, you have that preference piece, you have that risk piece, so it does give us that actual utility value. Next. Okay, so here's just a very quick example of how we go about calculating expected utility. So let's say we want to know what the expected utility of having this particular symptom is, right? We have to look at these different nodes. So let's say, well, we can either have relief. There's a certain probability that we will achieve relief, or there's a certain probability that we'll have to have something amputated, right? Well, okay, we need to know, though, if we end up having to have an amputation, what is the utility associated with that? So we could first calculate that arm, right? And we would say, okay, well, if we have to have something amputated, let's say there's a probability of 0.6 that we're going to just feel relief and be satisfied, right? And we'll say that the utility associated with that is 1, which is equivalent to perfect health, okay? And then there's a probability of 0.4 that we're going to die from complications or what have you. And the utility associated with that is 0, as we discussed. Okay, so if we calculate the expected utility of that, which is 0.6 times 1 plus 0.4 times 0, we of course get 0.6. Okay? So the same thing with the symptom. We can say, okay, well, there's a probability of 0.8 that we're going to end up in this arm, and the utility associated with that is 1. And there's a probability of 0.2 that we're going to end up in this arm, and the utility associated with that is 0.6, which gives us an expected utility value, which is just basically a weighted value of utility of 0.92. Okay, so this is essentially saying, well, what is an expected value? We're essentially just saying, what if you could perform this over and over and over again, right? On average, you can kind of think about it, where would we end up? So that's kind of another way to think about it, which is can be difficult when you're talking about something like this, but that's basically what we're talking about, right? We're assigning these probabilities and we're saying this is probably, this is kind of that value associated with that. This is that average value, if you will. Okay, next. Okay, so we talked about measuring the values directly. What about doing something more, which will probably most of you are more accustomed to if you've been associated with clinical trials or anything, and that would be using this generic health-related quality of life instrument. We give this to the participants, we get a value, right? How does that whole thing work? So that's what we'll talk about next. So first of all, as I alluded to a few minutes ago, there are quite a few, actually there's a lot. If you look through if you Google health-related quality of life instruments, you're going to end up with all kinds of stuff, right? So there's generic ones, as I discussed. There's disease and disorder-specific ones. And there's some that are preference-based, and there's some that are not preference-based. Okay, so the generic ones are nice because we can pretty much give them to just anybody, right? The disorder-specific ones are nice because they're going to be more likely to, on average, I should say, they're going to be more likely to be more sensitive to changes in that particular disorder. The problem is they may not be preference-based, and even if they are, they may not have been mapped to a utility value, which means we can't use them for quality-adjusted life years, okay? But at any rate, so you can see here just a few examples of some in each category. So we have generic instruments, let's say like the SF36, the SF12. But the problem is they're not preference-based, right? We have some disorder or disease-specific ones, like functional assessment for chronic illness therapy, asthma, quality of life. I don't know what the rest of it is, but anyway, or we have some of these preference-based ones that are nice, right? That are used, and we have values for those that were obtained using standard gamble or time trade-off. And then the nice thing is, on the next slide, we'll see that we have, so the SF36 and the SF12 have been mapped to like the SF6D, which we then can use to calculate utility values. So you can use the SF36 or you can use the SF12. We can then map it to the 6D, get those preference states, or those health states, right, and calculate utility values associated with that. So anyway, this just kind of gives you an idea of the range, and like I said, there are many, but there are things that you have to consider when choosing one. So oftentimes you might want to choose a couple, right? If you're just interested in kind of that profile measure of health, you may want to calculate, you may want to use one of the disorder-specific instruments that are out there, but you may also want to include, say, the EQ5D so that you can calculate QALYs and get kind of more of that economic component. Okay, so the questionnaire-based scales, like I said, there's kind of one question. So each item samples an aspect from a health construct or domain. And we talked about that a little bit already, right? Can we do these things? If so, yes or no, or to what degree? Not at all, somewhat, a lot, or maybe a Likert scale or semantic differential, something like that, right? So here's an example of the SF36. So I believe there are 36 items. Those can be mapped to 8 scales, right? And then those can be mapped to 6 different domains, which is where that SF6D comes in, okay? And then with those domains, we can calculate these various health states. So we talked about the EQ5D already, right? Now there are 243 different health states. I don't remember exactly how many there are with the SF36. I can't do the math in my head, off the top of my head, but at any rate, we can then assign values to those. Okay, next. Here's another example, the Health Utility Index. So that you can see that there are these various levels, these various domains, and then there are, say, 6 levels, 5 levels, so on and so forth. So the total number of health states with the Health Utility Index is 972,000 plus dead. 0.36 for the worst. So if you were to rate each one on the lowest, I think the 0.36 would be the value. 0 obviously for dead, 1 for perfect health. Next. Here's the EQ5D. So you have 5 questions, plus you have this visual analog scale, right? One of the nice things about the EQ5D is that in addition to, like I said, having pretty good psychometric properties and just basically that low burden on participants, is that it has a wide range of possible utility values. So with EQ5D, for example, there are actually health states that have a value below 0, right? So there are health states that people feel are worse than being dead, okay? And so at any rate, so you end up with this wider range. We don't see that very often, but it is possible. Okay, so the next thing that we need to do is we need to take those health states and we need to map them to an index value, right? To that health utility value so that we can use it in quality adjusted life years. So we take these large set of hypothetical health states, right? We explain them to people and we give them to the general public, as we discussed a little bit ago, right? To get that societal value. And then we're able to generate this algorithm and basically create this health utility value associated with these different health states. So now we can give that instrument to participants, right? And then they can tell us just basically how they're feeling in each of those domains. We can then map that to a utility value and then use that to create a quality adjusted life year, which I'll talk about here in just a second. Next. Okay, so in terms of these general or these generic health-related quality of life instruments, there are still, even if you find out that it's, okay, this is good, it's generic, it's preference-based, I can use it to calculate QALYs, well, you're not done, right? There are still further considerations, such as, what populations do those values relate to? So have they been valued in this particular population? So the SF6D, for example, has values that were conducted within a population sample from the UK. So if you believe that the population you're valuing is comparable to the UK, then you're probably, it's probably okay to do that.
There's US values now as well.
Oh, there are?
Yeah.
Okay, so that also has US values. The HUI, I believe, is only for one city in Canada, so that's fairly limited, right? EQ5D probably has the most that I know of anyways. There are you can look on the website, there are quite a few different countries that we have population values for. So that's always a good place to start, at least, I think. Next. Okay, so now the advantage of these types of instruments that they're relatively cheap and easy compared to standard gamma time trade-off utility assessments. So you get the instrument, you give it to your participants, and then you're done, right? You hand the values to your health economist, and you walk away, and we come back with our magic. You can do paper-based or computer administration. Like I said, community-based average utilities. Disadvantages is that the preferences are community-based. That can be a disadvantage, and only available for specific countries, as we discussed. And you're limited to the domains in the survey. So, in reality, like I said, I think the biggest disadvantage is it may not be as sensitive to a specific disorder as a disorder-specific one would be. But again, you also get a little more generalizability, I feel like. Okay, next. So this is an example. Ideally, probably had this slide a few before, but this is where it got placed. And so what I was talking about with the health-related quality of life instruments is that, first of all, the health-related quality of life can be valuable in and of itself. So this is another one. This is the EQ15, or not EQ, sorry. This is just the 15D. So there's 15 different dimensions. So you may want to be able to just look at, say, a health profile of an individual, right? Or of your patient sample versus average for the population, which is what this is showing. And be able to map it across these different dimensions, right? So by itself, it can be valuable. And then what we can do, of course, is we take the values from these domains and we are able to put them into one score. Okay, next. Another nice thing that we have on our website are these different fact sheets. So in a minute here, I'm going to show you some examples of studies that we have done in terms of dealing with health-related quality of life, especially in substance use disorder therapies. But as you know, some of these papers, especially if that's not your field, can be difficult to digest, right? But on our website, we have fact sheets for many of these papers that that make this information much more easy to comprehend and get a general idea of what it is that we did exactly. So anyways, we have lots of great resources. That's one of them. So this is one that a colleague of ours did along with Dr. Schackman and members of CALDAR as well, Ying. And they looked at the short-term health-related quality of life during opioid agonist treatment. Next. So there were 2 different trials from which individuals were used, and I believe the SF6D was given. And so there were 4 patient groups. So prescription opioid-dependent individuals in time-unlimited treatment with complete follow-up. Heroin-dependent individuals in time-unlimited treatment with complete follow-up. And then in the other study, you had the 2 groups, the prescription opioid-dependent individuals in short-term taper, complete follow-up, and those in prescription opioid-dependent individuals in extended stabilization and taper with complete follow-up. And so individuals were given the SF6D, and
SF36.
it was translated to the F6D. Okay. So linear mixed effects models were fitted to determine independent effects that treatment had on quality of life, and then that was used to characterize the quality of life trajectories. What they found is that treatment had a similar, immediate, and modest positive association with quality of life in each patient group, right? And the effect sizes varied between 0.039 and 0.071. Okay, and then after initial improvement in quality of life, you tended to see that it decreased slightly or at least increased at a diminishing rate. So these are the long-term trajectories. Short-term trajectories in each group associated with that. And so as you can see, like I said, it's going up immediately and then kind of either leveling off or maybe diminishing a little bit. This is another study, slightly more recent, that Dr. Schackman and some of our other colleagues worked on, where they looked at health-related quality of life for individuals with opioid use disorder in these different health states, as well as their significant others. So they did a cross-sectional internet survey, I think about 2,000 people? I thought it was up there. But anyways, U.S. population representative respondent panel. Like I said, they assessed health utility for 6 opioid health state vignettes. Active injection opioid use, active prescription opioid misuse, methadone initiation, methadone therapy stabilization, buprenorphine Suboxone initiation, and same thing, stabilization. Okay. Responses that failed the invariance criteria were excluded, and they compared the mean utilities across health states using linear regressions to look at significant differences overall and in pairwise comparison. So I'll show you the results from that here. This is the slide that I showed you earlier in terms of how those were derived. And this is the one, same thing, but for the spouse, which is was very interesting, right? Because no one's really done that before. We have some limited information in terms of caregivers and things like that, but especially when we're talking about substance use, that's even relatively rare. But so this is great. I feel like this was a very important addition to the literature. So these are the standard gamble utilities for individuals versus spouses. So you can see up here that we have the levels for the individuals, and here are the spouses. For the individuals, the utility values ranged from 0.574 for active injection misuse, 0.761 for the initiation stage of buprenorphine therapy. So to kind of get an idea how that compares to the spousal utility values, first of all, you can see that they're all well below 1, right? They're all below perfect health. They are, as you might expect, they tend to be higher than the individual who's actually suffering from the disorder. But again, you can see that they're also, they're impacted, maybe just less so. Okay, next. The other nice thing that they did is that, so we had the vignettes that you saw just a minute ago, but then they also gave to at least a select subgroup, right? They did it for everybody. Be expanded.
Well, you can see the numbers there.
Oh, yeah, okay. So, but they gave these expanded vignettes, so incorporated some of these other things that we know to be associated with substance use disorder, talking about, some more of these like societal type impact measures, but criminal history or criminal activity. What else was included?
Losing your driver's license.
Losing your driver's license, things like that. So it's not just your health, but there's also these other things that you're probably going to have trouble with, essentially. And so you can see that those all tended to lower, once people kind of took these into consideration, that tended to lower these utility values below what they were without those expanded descriptions. So the conclusion from this is that, in the opinion of the US public, injection opioid use disorder results in worse health-related quality of life than prescription opioid use disorder. Methadone therapy results in worse health-related quality of life than buprenorphine naloxone therapy. And spouses are negatively affected by their partner's opioid use disorder, and particularly in early treatment. And then health-related quality of life, physical and mental health domains do not capture the full effects of opioid use disorder on quality of life. That's kind of that big take-home message, which we talked about before. And it's just kind of shows us that that is the case. Okay, so the next thing that we want to talk about is really going to focus on quality-adjusted life years. So these are some of the possible outcomes. So you have health expectancy. You're looking at quantifying that current health of the population, right? So we can do life expectancy. We can also do quality-adjusted life expectancy or quality-adjusted life years. So we're not going to go into all these. I'm going to focus primarily on QALYs. But there are other alternative measures that you see occasionally, and depending on the context of the study. But for example, years of life lost, disability-adjusted life years. So just kind of know that those are alternatives. In general, health economists feel that the quality-adjusted life year is still superior to those alternative measures, but they do have places. Okay, next. So quality-adjusted life years, like I said, so it's this preference-weighted measure of health outcome. So basically what we're doing is we're not only considering the quality of life or the utility associated with the health state that an individual's in, but also how long they were in that health state, okay? And it's nice because it's comparable across interventions, programs, diseases, disorders, right? It gives us this common denominator, which is very important, especially if we're trying to determine how to allocate resources across more than just a particular disorder, right? So incorporates patient values and preferences for different health states, incorporates morbidity and mortality, and kind of brings it into a single measure. So like I said, quantity of life, health-related quality of life. So I kind of just jumped ahead of myself there. But let's say, for example, that you have a health utility of 0.8 that's associated with a particular breast cancer state, right? So if you have to live 1 year in that state, that would be the equivalent of 9.6 months of perfect health, right? That's kind of how that works. 2 years, of course, then you would be worth essentially 1.6 years of perfect health. Okay, next. So like I said, we have these weights associated with each health state. Generally, the range is from perfect health, which is a 1, to 0, which is death. As I mentioned, we can value states worse than death depending on the instrument that's used. But so this is basically how we calculate the quality. Like I said, we take these assessments. Let's say if we're doing a trial, we'll assess health-related quality of life at each, at multiple points throughout the trial. And then we, of course, will weight that by the utility associated with the state they were in at that point and sum those up. So this gives you an idea of what we're actually looking at. So you can see that top line would be with treatment. This would be quality of life without treatment, and you can see that we have these different points kind of where it's captured, right? And so if we look at the total area under one of those curves, that would be the quality of life associated with, let's say, that treatment, right? So what we're really interested in, because as Dr. Schackman mentioned, right, we're interested in that, that the difference between these, right? That incremental cost or that incremental benefit. So what we're really interested in is the difference between these, so the area between these curves. That gives us what is referred to as quality adjusted life years gained from treatment, which is usually what you end up with when you're looking at a cost effectiveness outcome. So it's cost per quality adjusted life year gained. So you're always comparing it to something else, right? Next. So a few limitations. So there's this assumption that all QALYs are of equal social value. So there's this famous quote by Weinstein in his '88 Health Economics Journal article, right, that a QALY is a QALY is a QALY. Well, that may not necessarily always be the case. And as we talked about, right, we may actually want to spend more on one population relative to another. The other thing is it may not capture all benefits that are associated with a healthcare intervention, right? So for example, even we kind of talked about that spousal offset a minute ago. Then of course, I mean, there's things like improving someone's life and getting them into therapy may make them a better parent. Well, as we know, there's this ripple effect that kind of just keeps going. We're not going to be able to capture all of that, right? Generic instruments, like I said, may be insensitive to some medical conditions relative to a disorder-specific one. And then many condition-specific measures, however, not capable of producing QALYs. So we kind of just a summary of all that I discussed before. Also, preferences may vary by age, gender, race, so on and so forth. Valuation of life years does not equal the value of life years at all ages. So, we may end up with some discrimination against the elderly, for example. And so those are things that we have to be careful of when we're talking about QALYs. And then there are trade-offs between quality of life and survival. So, right, so the fact that if we have, let's say, many small improvements or one big improvement, are those really the same thing? We're saying they are, but is that actually the case? For example, improvement from quality of life. If you're going from 0.1 to 0.5 versus going from 0.5 to 0.9, is that really the same, right? If we're going from basically our deathbed, if you will, to being able to, let's say, at least walk around and do things, is that we really going to place the same value on that as going from a 0.5 to a 0.9? I don't know, but probably not. So this is just something you can spend a little time looking at later when you get the slides, but it just gives you just kind of this good overview of how we actually get to here, right? To that quality measure. So we spent some time talking about this, and this is what a lot of people are going to be most familiar with, these generic algorithms, or sorry, these generic instruments, and how we can apply that algorithm and get those scores and end up here. But there are also these methods, right? These condition-specific measures, and there are a few different ways to get there and be able to get that index score, right? So essentially just talking about the two different ways that we end up here, where we have that index value, and we can then weight the time spent in that health state and generate those quality-adjusted life years. In summary, quality-adjusted life years combine both quantity and quality of life. They give us that common denominator for our cost-effectiveness analyses, right? Health-related quality of life has many uses on its own. For example, I showed you that slide where you can just use it as a health profile measure, if you like, which we all know is an important treatment outcome in and of itself, right? So even if you're not going to use it for QALYs. And then, as I mentioned, we do have some limitations when we're talking about quality-adjusted life years, but the general consensus seems to be, that we're better off improving the limitations that we have with quality-adjusted life years than we are trying to switch to an alternative, like disability-adjusted life years or the YLL, things like that.